I'm going to start and kind of kick us off here and say that patient-centered, or sometimes called person-centered care, is frequently invoked and synonymous with thinking about considerate, ethical care of patients with cancer. The idea of putting the patient in the center of care seems, on the one hand, redundant. I mean, isn't that how medicine is supposed to be practiced? But also something that we must struggle with. Perhaps it's a beacon for us to be honest about what we are focusing on instead of focusing on patients. The concept is straightforward, but how we understand it and use it is not. Certainly, some initiatives are purportedly patient-centered, but may not feel that way to patients. How do we achieve a balanced, good enough care that aligns with what patients want and what the patient needs for optimal care? To my mind, there's no better way to be patient-centered than to appreciate the intricacies involved with making this assessment. Does my patient have adequate understanding of the important issues, and to what extent can they engage in care? I always think about how ironic it is that patients need to make pivotal decisions in their lives at exactly the same time that they are perhaps least well equipped to do that. We must appreciate that cancer fundamentally changes people's lives. They require time and patience to come to terms with these changes, and their perspectives and even values are probably evolving. Clinically, we institute decision-making capacity as the necessary skill to decide if patients are equipped well enough cognitively or emotionally to engage in these decisions. While the procedure is important and not perfect, the broader ethical context is often overlooked. Perhaps this may be the key to clinicians thinking more about decisional capacity and gaining another perspective on being patient-centric. Louis, I want to ask you that if we were to go back in time, let's say we were working in a 19th century hospital, and someone said, I'd like to get a decision capacity referral. How might that person look at me? Would that even make any sense?
If you go back to 19th century medicine, we didn't have a lot of specializations. The way that care was delivered was through a very intimate relationship between a physician and a patient. And in some instances, a physician and a patient plus the patient family. More importantly, there were a lot of other contextual data that those physicians in 19th century were familiar with. They weren't living far away from their patients. They were living in the same communities. They knew whether these patients go to church, temple, or practice any form of religion. They were familiar with the patient's belief system and customs and traditions. And because it was so community-centered, they somehow knew about those patients' ability to understand. And in my view, based on books and other anecdotes from past times, I think they had it relatively easy in comparison to us nowadays and the way that modern medicine is practiced, but also the mega urbanization that has happened in the 20th century. And in the context of ethics or psychiatry, we have to be able to try to size or capture an entire dimension of a human life in a 30 minutes or 60-minute encounter. That is what we modern clinicians are facing with, are confronting when we are being asked to think about what I consider to be one of the most important aspects that speak about the integrity of a human being. your ability to think, to make major decisions.
What I hear you saying is that this 19th century physician would almost have no problem with substituted judgment and saying, yeah, I can speak for this person because we share probably a same cultural background. We've probably known the person, etc. And in today's day and age, with modern care, we're multicultural and patients come from all over, and we may or may not be similar in our backgrounds. And so the concept of it's in and of itself of decisional capacity, without say the nuances of like informed consent and all these other things, just weren't even really thought about at that point. Let's skip ahead to the 21st century. Tell us, just walk us through. Can you explain what decision-making capacity is and how we provide that determination?
I was thinking when Louis was answering your previous question, a question comes to my mind whether they were as attentive to patient autonomy as we are now, this day and age. Maybe they assumed the values of the people in their community and made paternalistic decisions. So all that is to say, I think glad we're in 21st century, glad we're making decision making capacity assessments. So what is it? So decision making capacity, the simplest way to put it, it's a person's ability to make a decision for the decision at hand, for lack of a better word, in that point in time, while appreciating the potentially foreseeable consequences of that decision. A lot of the time, so I'm a psychiatrist working in a cancer hospital. A lot of the times when we get called to see patients for capacity assessments, it's for a number of different reasons, but most commonly, they're unsure if the patient has capacity or not. The patient refuses an intervention or some kind of medical procedure. And there are also times that it's an urgent situation, a decision needs to be made, and they're unsure and they're calling us. Maybe if I walk you through what I do when I see a patient, it would help explain. So first of all, when I get the capacity assessment, I'd ask the referring team, so what decision are we referring to? Meaning, decisional capacity assessments have to be decision specific. The law has allowed the clinicians to make these decisions, to make these assessments, but only based on specific decisions. So as a clinician, I cannot make a global capacity assessment. And sometimes clinicians misunderstand that, right? So when I get an outpatient consult for a patient who's about to start cancer treatments, and if the clinician is asking me to make a capacity assessment, I'd ask the clinician, what's the treatment you're going to be proposing to the patient? And the clinician may say, well, we haven't talked about the treatment yet, but I want you to assess the capacity first before we can start treatment. That's a big stop sign, right? Because the patient hasn't even heard the information they should be making a decision for. So that brings us to the first part of the decision-making capacity. That's patient's ability to understand the information that is presented to them. So the information must have been given to the patient so that we can assess their understanding. In the inpatient setting, when I'm asked to do a capacity assessment, I typically want the primary team there in the room with me, because if the patient has any questions about the procedure at hand, I want them to explain it to the patient, and then I can assess the understanding. There are times where you go into the patient's room, patient may not have absorbed the information in the first place when they spoke with the team. So they're at a loss, but not because of any lack of understanding, but there wasn't enough time to really hear that information, to consume that information. They need to hear it again. The other thing I would assess for would be the patient's ability to appreciate the risks and benefits. And typically the law would say being able to understand or appreciate as much as a reasonable person, right? So I don't expect the patients to tell me in detail all their genetic mutations and how they may explain their treatment response to certain immunotherapy, but to have a basic understanding and appreciation of the risks and benefits of the treatment. Then I move on to how the patient is coming to a decision, the rationalization part of it. One of the things sometimes we look for in patients with cognitive changes or serious mental illness is whether their cognitive difficulties or delusional thinking are interfering with their ability to rationalize their decision. In other words, if a patient is refusing their heart surgery because they're delusional that if anyone were to touch their heart during the surgery, their lives will be taken away. They'll have some kind of spiritual experience of sorts, some kind of a delusional way of thinking, then they're not rationalizing, they're not rationally making a decision. And then the final part of it is communicating a choice. And it's interesting because sometimes we would go in, talk to the patient, we would think that patient has capacity, they would communicate a choice saying yes, and then 2 minutes later, someone goes in, they're kind of indecisive, they're saying no. So it's communicating a consistent choice, which is the highlight.
The other part that I've also read about is that our model for providing decisional capacity leans heavily on the cognitive aspects of the decision and less so on the affective or emotional part. So I think in a sense, when the patient's upset and whether this decision is something they would normally make under other circumstances, that's kind of something that we don't have as much to go on, essentially. It also sort of speaks to this broader issue of other ethical issues, other ways of kind of making judgments. Are we making a judgment for the patient, with the patient, et cetera? So I'll ask Louis if he wouldn't mind explaining for us how he sees it that decision-making capacity is actually related to ethics and why is it important?
Decision-making capacity is extremely important in medicine for the simple reason that as we have evolved as human beings on this planet, we came to understand that individuals, any human being, whether that human being has full ability, partial disability, or severe disability, that is a human being with what I consider to be absolute rights. So the way that I look at decision-making capacity in medicine is through the lens of rights. It's a right-based approach to it. So there are many ways you can look at it, but for me, as an ethicist, that's the way that I look at it. So I am entitled to those rights. They are not relative rights, and they are not given to me because people feel like it. So the body, the integrity of who I am, my body, my mind, who I am, rests fundamentally on those rights. And when I go to a hospital as a human being to receive care, I anticipate, and it is built in that relationship, that the hospital, the healthcare organization, the physicians and nurses, and all other groups of people, members of the healthcare team caring for me, needs to respect me as a person. By talking about patient-centered care, I call it person-centered care, because many times we have those relationships. Granted that when I go to a hospital, whether it is for a healthy follow-up, a healthy checkup, I have adolescents who come and they come just for a follow-up. They're not sick. They come because they go into college and they need a shot against meningitis. They're not sick. We call them patients, but at the end of the day, they are persons. So that's the way that I view it.